Good afternoon, everyone. Welcome to this meeting of the Rotary Club of Greenville, aka the Downtown Club. We are glad that you're here. We have a full program and a guest speaker. We're going to start out with our invocation and followed by our pledge. You can remain seated if you like now. I'll call you to attention when we get to the flag. Good and gracious Creator, Sustainer, we are so pleased that we can gather today. This is a special time of remembrance and celebration for so many faiths. And we also recognize a time of prayer and contemplation for peace in this time of war in Europe and Africa. Despite all the chaos and upheaval, help us understand that we were created for service to others. Remind us that giving of ourselves, our time, and our resources are the necessary commitments that bring understanding, community, and lasting peace, both here at home and around the world. In loving mercy, may we honor one another with justice and love and unity. Now bless this food prepared for us. May we take it in gratitude and thanksgiving. Bless the hands that prepare this meal, and especially those who serve and graciously wait upon us today. We ask all this in your honor and glory. And in the tradition of many faiths and cultures, may all this hold true, and may it ever hold for us and for many. And may all people say amen and amen. Please stand and salute their flag. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. Thank you.
All right, it is my pleasure to tell you today that we have several visiting guests with us. I'd like to give you a warm welcome and take a moment just to introduce you. It actually was about a year ago that I too, for the first time, was a guest here, and it has been an incredible journey I've had. There are very inspiring people in this room, and I've enjoyed serving alongside of you this year, not just in our community, but connecting with you too. So I would encourage the guests to learn more about Rotary today and maybe even consider joining. So as I call your name, please stand up and then remain standing until we get to the end of the list. So we've got Wells Dunlap, guest of Phil Carter, Bonnie Iserman, guest of the club, Greg Pickett, guest of Rusty Infinger, Aaron Predmore, guest of Bob Morris, Don Lilly, guest of Jim Purrier, Rosie Davis, guest of Chris Manley, Tom Traxler, guest of John Malden. And then we have several visiting Rotarians with us today. The first one, Kelsey Ryder. She's a member of the Greenville City Center. And then we actually have Paul Hoffman as well, all the way from Mannheim, Germany. And he told me the name of his club. I don't dare pronounce it, but he said it translates into very old. So welcome. Warm welcome to all of our guests today. Welcome.
Well, President Ramona and the fellow Rotarians and the guests, I'm here to tell you a little bit about the peace conference coming in May. It's about the conference on peace and conflict resolution. Good time to do it, with the emphasis on the unconscious bias. You know, when I always thought of bias, I always thought of racial bias. But this conference goes a lot beyond the racial bias. It's about bias, period. And it's about the kind of the biases that we have in our thoughts, in our words, in our actions. We encounter them every day with dealing with others. It may be our family, it may be our friends, it may be anybody else we communicate with. Let me ask you all, how many of you think that you have unconscious bias? Raise your hands. Great. The, you know, experts like Jessica Sharp says, if you have a brain, you have a bias, which means if you don't raise your hands, you don't have a brain. Or is it that you have a bias and you are not aware of it? You know, that's it. So this is what this conference is about. Some may think that their bias is in their genes. You know, I've been doing this all my life. It's in my genes. I can't change that easy. Is it? Now, a cell biologist and professor of medicine, Dr. Bruce Lipton, says no. He's in his book, I read Biology of Belief. He says your behavior is 95% due to environment and 5% due to genes. In his study of cell behavior, human cell behavior, he has shown that human cells adapt to the environment they live in. And the brain experts say that our mind is comprised of two interdependent minds, a conscious mind and an unconscious mind. The conscious mind is the one which is a creative mind. You know, it thinks and it does things. The unconscious mind is an autopilot mind. It will carry on habits it has learned from experience, from the environment, and it has been exposed to. Now, these are programmed in our mind. These habits are programmed. It just happens automatically. These we may have learned from our parents, siblings, friends, neighbors, listening to others, seeing actions of others, reading, watching TV, all kind of communication. He says much of the programming of our mind or unconscious mind is done by the age we are 7 years old. Isn't that interesting? We already know what we're going to do when we are 7 years old. But you know, the question is, okay, what are we going to learn from this conference? Well, I think this conference is going to educate the participants on their kinds of the biases they may have and the conflicts which they create. It will help the participants identify their own biases through the self-reflection and discussion with others. It will equip the participants with the skills to challenge their biases and deal with the biases of others, to resolve conflicts resulting from the biases as well. It will also provide resources to continue to challenge the biases after the conference is over. When you go home, you will learn something. So focus will be on breaking down the communication barriers caused by the biases so that we can learn how to communicate more productively with others. So I encourage you all to join this conference. It'll be a lot of fun while we are learning something that you may not know. And on the table outside, we have cards here, and pick up one or more. Peggy has it on the table, and pick up one or more and go register yourself. And if you have friends or anybody that you know, family, invite them. And if you have a conflict, you cannot come, donate your tickets, buy the tickets and donate it to the students who can afford. So thank you for listening to me, and I hope to see you all there. And it'll be a lot of fun.
Thank you, Surendra, for that important message about the Peace Conference. They do have an incredible lineup of speakers, and I would encourage all of you to take that message to heart. As many of you know, I'm Wade Culp. I'm the president-elect of this club, and it's my pleasure today to introduce our speaker. President Ramona couldn't be here, so I get that task, and it's just a delight for me because I'm introducing someone I'm tempted to call the Dr. Anthony Fauci of South Carolina. But it may be more important in introducing Dr. Brandon Traxler. Perhaps we should say that Anthony Fauci is the Dr. Brandon Traxler of the United States. So but she is a dear friend, and she is the Director of Public Health for the Department of Health and Environmental Control. In that role, she leads over 1,900 employees and oversees delivery of public health services at over 70 public health sites around South Carolina. She got her undergraduate degree at Clemson, a medical degree at the University of South Carolina School of Medicine, and a master's of public health at George Washington. And as I alluded at the beginning, she became familiar to many of us during the COVID-19 crisis because she led South Carolina's response to that crisis. And she was a trusted voice, a calming and reassuring voice on radio and television, often beside our governor, in leading our COVID-19 efforts. And we are so grateful, all of us as South Carolinians, for her service. So I know you will enjoy her remarks today, and please give a warm welcome to Dr. Brandon Traxler.
Thank you, Wade, and thank you everyone for having me here today. I have to say that the part that Wade left out is that I am a native Greenvillian, and I'm happy and honored to still call Greenville home. I burn up a lot of miles on 385 and 26 several days a week going to and from Columbia, but it's worth it to still be here in Greenville and call this home. So I know you all know how special of a place this is. And I have to say, for what Wade was saying, it still is a little mind-boggling to me sometimes because the last 2 years have been a little bit of a blur. And I think back to the start of our COVID-19 response in South Carolina, and it started with 5 people at DHEC in mid-January of 2020. Started putting together plans, thinking, oh, we might be needing to monitor some travelers coming back from China. Then March 6th of 2020, by then we certainly were aware it was coming to South Carolina, and it did. And has continued on since then, though I'm happy, as you see from the title of my presentation, to say that I think it's time we can start looking beyond at least this emergency part of it, at least beyond the crisis portion of it. And so I'll speak about that and how we learn to kind of live with it in low levels. But I am certainly also well aware of the loss of lives and the number of people who have been sick, the loss of income. There's been a lot of loss during the last 2 years. And so I just want to take a moment to recognize that. But so now it is time. At DHEC we are, nationally we are, I think even worldwide, looking at COVID-19. How do we do this? And how do we then keep going with all the rest of public health that we deliver? Much of which has continued behind the scenes during the pandemic, but certainly there have been portions that have not gotten as much attention and focus as it normally might have because, fairly enough, there's been a massive pandemic going on, a once in 100 years. So this is kind of South Carolina's pandemic by the numbers, and this is as of late last week. We had almost 1.5 million cases in South Carolina out of the 5.1 million people that we have in the state. We have had 17,000 plus individuals lose their lives associated with COVID-19. And many of you know, and if you don't, I will tell you, I lost my own grandmother to it early on in the pandemic. It was one of the hardest things, knowing that this was something I was spending every waking hour, and most of my hours were waking, focused on, but I still couldn't even protect necessarily my own family. And it's just been certainly a motivator throughout the pandemic to keep going so that nobody else had to experience that. As of Thursday, we had just at 250 people hospitalized with COVID-19 in South Carolina. That's down from a high of over 3,000 at our peak, which was during the peak during Omicron. We only had 54 in the ICU, and I'm happy to say only 27 on ventilators. I have not seen the email, but it will come today again with updated numbers, and I anticipate they're even lower than that today. And again, the ICU and ventilators, we saw those peaking certainly during Omicron, but really we saw the worst of the severe cases, I would say, during Delta, during that wave back in the fall. We have had 4,600,000+ people tested, and that's not tests performed. Those are actual distinct individuals in our state who were tested. So the actual number of tests is significantly higher. If you're one of my family members, then you've probably been tested multiple dozens of times because that's how we roll. We did dinner at Christmas this year for the first time in person, and everybody got a rapid test when they walked in the door. We are at this point looking at 5 years and up in South Carolina, all eligible people in the state that are eligible for vaccination. We are at just over half being fully vaccinated, having gotten either the 1-dose Janssen or both doses of the Pfizer or Moderna. You'll see that we have given just shy of 1 million third doses or booster doses. We are still lagging some in that regard. So I encourage all of you, if you are fully vaccinated and eligible for your booster, but you haven't gotten it, go get it. It really has shown that with the newer variants, with Omicron and with its subvariant BA.2, that getting that booster shot on board really does boost your protection. We also still only have about 15+% of the children who are eligible. And certainly we are all looking forward to the day when the last of the population, those under the age of 5, can be eligible for vaccination. Nobody more so than myself who has a child under that age of 5 and can't wait for her to be able to get vaccinated. This is what we call an epi curve. And so if you remember back in the beginning 2 years ago, everybody talked about flattening the curve. This is what they were talking about. And so you can see we've had 4 surges. I will admit that first summer hardly seems like a surge now in hindsight, but it was. And even that first winter, which seemed so bad, it was, but certainly in terms of volume of cases, it did not compare nearly to Omicron. The good thing with Omicron is when you look at, which is this most recent peak here, when you look at our hospitalizations, you see that there's not quite the disparity. There's not that difference. It's been more equal. And the teal line is the adults, the pink line are children or pediatrics under the age of 18 being hospitalized. And you see though, for the adults especially, Delta and Omicron were really about the same number of people that were being hospitalized. And so that shows you that Omicron thankfully caused less severe disease. It might have been more contagious, but it caused less severe disease. We saw less of a proportion of people who were infected who ended up having to get hospitalized. And same with deaths. Actually, it was slightly lower, that peak during Omicron, than that first winter when nobody really was eligible for vaccination or were just becoming eligible, and then during Delta. Deaths are a little bit of a lagging indicator is what they call. So it does lag a couple weeks behind the cases. So we are not quite as far down as we are on deaths as we are with cases or even hospitalizations at this point, but it is coming down, I'm happy to say. So we've had all these cases and all these hospitalizations and all these deaths. And so now where do we go from here? Because we don't want to keep just having waves. We don't want that to become a sine wave type curve. And thankfully, this virus is evolving to really help us out in that regard. The more recent variants are more contagious, but they do cause less severe disease. That combined with at the same time us seeing just a very available, very effective and safe vaccine, as well as an increase in availability of effective treatments. All of that combined has led us to the point where we really can start looking at COVID-19 as being more endemic and not pandemic. We will still see some increases in cases, but they will not be, we don't anticipate them to be as severe. That being said, my crystal ball, I tell people, has been busted this entire pandemic. So I can't tell you that another variant that's a lot worse and a lot different won't come along. But if this virus follows the pattern that's been showing and with other viruses often show, then this is what we expect. We would not be surprised if this is seasonal even. Though, again, a lot of that's going to depend on the variants that emerge. So our focus now is less on preventing actual infections and more on preventing severe diseases. So if you think about it, the COVID-19 virus, the SARS-CoV-2 virus, is part of the coronavirus family. You remember, I mean, that's one of the original names of this. Some of us remember its name that got abandoned, the 2019 nCoV for novel coronavirus was the first CDC name for it. The coronavirus actually causes, roughly about a third of common cold cases. Other coronaviruses do. Now, certainly then there are the other extreme with the SARS and MERS that they can cause, but this one may end up being in between and hopefully looking closer towards that end of the spectrum with the common cold. And so you think about the common cold or you think about flu, and we certainly try to prevent cases. We don't want people getting sick. Nobody likes to be sick. But we really are focused on preventing the severe cases. And so that's what we're going to be doing with COVID-19. We certainly also want to avoid the hospital systems being overwhelmed. So again, that ties in with severe disease. More hospitalizations, the more resources have to be focused to them. And certainly then, worst case elective surgeries get canceled and postponed, even some of the semi-elective. You see a lot of the focus of staff having to get pulled to focus on COVID patients. And so we want to avoid that strain on the healthcare systems. And so I will tell you that I do not follow data now. I do not look at cases. I used to be able to tell you every day by roughly this time of day, I could tell you how many cases we'd had. Sometimes by 6 a.m. if my epidemiologist was texting me based on his midnight data pull and found something interesting. I now don't look at those. I can't tell you off the top of my head how many cases we had yesterday. I'm looking at the hospitalizations and the deaths, but especially the hospitalizations, because to me, that represents certainly the majority of the deaths are occurring in hospitals. So that's going to lead to that. It's more real time. It's not as much of a lagging indicator, and it'll reflect how the hospital systems are doing in terms of strain on them. So we also are going, as you know, we're shifting some of our strategies. Some of you have noticed we've stopped doing our daily 1 o'clock website updates with all the data. I'm still weaning my mother off of the daily data. She was one that became an armchair epidemiologist and actually got very good at it. But I'm still working with her on learning, that looking at the trends, so week to week, is more important than looking at day to day. And looking at the severity measures are more important than actual infection measures. We also have changed shifted our testing strategy. So we're going away. For the longest time, PCR really was that gold standard and is what we pushed everyone to. Though it still is the most accurate. However, the rapid antigen tests have become much more accurate over time, in part because they've had longer to develop them, and in part, I think, because the FDA has cracked down some in terms of what they'll give an EUA, an emergency use authorization for. But those have also become, the more accurate ones have become more widely available. And so we're shifting to using more of those because you can have an answer in 15 minutes. I tested my 1-year-old this morning when she woke up with a cough. Like I said, my family gets tested a lot. I don't want to be that parent that sends their child to daycare with COVID. But I had an answer 15 minutes later. If she had been positive, I would have known. I could have kept her home, kept her away from other people. Whereas if I had taken, let's say even if I had taken a swab to our lab in Columbia, it still would have at least been probably this evening, if not tomorrow. And that's if I pulled strings and did all sorts of stuff. The PCR tests just take longer. They take a day or two to get back. During that time, people have infected other folks because let's be realistic, people are not usually isolating at home while they're waiting on their test if they have mild symptoms. So the public health benefit of having that earlier answer and knowing how to act on it is bigger than the little bit of accuracy that you might lose with using the rapid test. Because I will tell you, it is a very little bit at this point. I also tell people to follow the instructions on the box. I will fully admit that when we were first thinking about this strategy back right before Christmas, I guess, and we're looking, because we were realizing there were more and more of these more accurate tests, I started going on Amazon and ordering some of the different brands, partially to see how long it took, and partially because I wanted to see how easily they could be performed. Was it realistic to think that we could hand these out in our health departments and average public be able to perform them? They come 2 tests to a box if you haven't looked at it. And so I opened the box and I took one of them and started looking at it and reading the instructions. My wonderful husband took the other one and immediately started opening things. Please read the instructions. There are some nuance differences between some of them, okay? So read the instructions, follow the instructions. You can trust the result then if you did it according to the instructions. And have your answer very quickly and know to stay away from other people if you're positive. We also are not doing that universal contact tracing, and that's kind of still being phased out. We surged up to, I think, over 700 case investigators and contact monitors at the peak of COVID-19. And that's from the roughly 25 or 30 epidemiologists we have during pre-COVID times throughout the state. So we staffed up considerably. We are still decreasing that down. And so some people are still getting calls, but we're focusing more on helping out settings where they're high risk. So places like a nursing home, a homeless shelter, a detention facility, places where it can spread really easily, a college dorm. We're focusing most of our attention there. Really, we were not finding there was not a whole lot of benefit occurring with the contact tracing for average folks. A lot of folks weren't quarantining. A lot of folks weren't answering our phone calls. And so certainly if you know you have been exposed, if you were vaccinated, that's great. Go get a test a few days, 5 days after you were exposed. Otherwise, if you're not vaccinated, certainly I would encourage you, if you will, to quarantine for those 5 days and then get a test. But the main thing is knowing so you can go get a test. And I think there's a helicopter out there. Sorry, the former surgeon in me listens to things like that. I will tell you also that our health departments pass out the at-home rapid tests for free. So you can go and get a box with 2 tests. And you didn't hear it from me, but we're getting ready to increase that where you can get, for other people too, if you go. So go get a box from the health department. The one in Greenville just moved to Halton Road. So we're out there with DSS and family court. So this map is actually a little old. This is kind of looking at the future. I'm happy to report that as of Thursday night, which was after I submitted these slides, Marion and Dillon counties turned green. So as of this past Thursday, the entire state of South Carolina is green, according to the CDC. And if you have not looked at their new measures, rather than looking again at the spread of COVID, they're looking at things like hospitalizations, hospital admissions. A little bit of the equation is how many cases there are, but it's more that severity. It's giving green, yellow, reddish, orange in terms of whether you're low, medium, or high for COVID levels in your community. And then their guidance around masking is based on that. So with green, the guidance is certainly anybody can mask that wants to. If you're high risk, certainly you're especially always welcome to, but at green, there's not a uniform recommendation for public for masking. There are still plenty of unknowns. Like I said, that crystal ball is busted. We could have new variants that surprise us. I'll tell you that Omicron kind of came out of, I don't want to say nowhere, but usually you see a pattern where they build on each other. So you would see Delta, and then it would evolve. That Delta variant would evolve and mutate further and become the next variant. Instead, it went back to the beginning. It went back to the original virus and mutated from there. So it's called a whole separate lineage that Omicron came from. So this virus does not play by the rules. It does not play by the playbook. But we're trying to control it and make it play by the rules. There will be future surges. We may see an increase before too long with BA.2, that subvariant you may have read about with Omicron. However, we don't have any reason to think that the severity will be worse. And I have done some research and had my team do some research, and it looks like the level of protection from that first Omicron wave will be somewhat protective with BA.2 as well, in terms of immunity. The latest CDC, what they call nowcasting, which is their fancy forecasting, is estimating that roughly about a third of cases in the US right now are due to BA.2. But we're not seeing, and I just learned that from our lead epidemiologist this morning. That was his 6 a.m. fun fact for the day. The good news that I responded to him, I think somewhat coherently, was that's great because we're not seeing a corresponding significant increase in cases, at least not yet. And so that's encouraging. Booster shots. I do think we're going to need more booster shots. I don't know what the FDA is going to do about the most recent applications from Moderna and Pfizer. But I do anticipate that this would probably become something like the flu vaccine. The flu shot every year, believe it or not, is a booster. You may not realize it, but if you were little and you got your first one, my 1-year-old got 2 this year. It's her first year getting it. That was her first primary series. Every year after then is a booster for the flu shot. I know that Moderna and Pfizer are both working on combination flu and COVID vaccines so that we could even, I think Moderna told us that not this fall, but the next fall, we could hopefully have even a combination one. I will tell you also that these vaccines are very safe. I trust them. I have looked into the science. I enrolled my own daughter in the clinical trial for the Moderna one. That's how much I trust them. So I would obviously not have put my precious baby girl, my pandemic baby, that came right in the middle of the first winter surge in danger. And so if I didn't have full trust and if I had not fully explored myself and looked at all the data and science behind them. So again, the vaccines are important. Get tested when it's indicated. When you feel symptoms, and these days, a lot of times, especially if you're vaccinated, it may just be a scratchy throat. That's why I said a lot. In my family, you get tested a lot. But that scratchy throat and all may be COVID. The good news is then you just need to isolate for 5 days. Assuming you're feeling better at the end of 5 days, you can go back out into the world. Just wear a mask for another 5 days. But take those actions, protect your loved ones, and certainly wear a mask if it's indicated, if this map were to change. We do know that the masks work also and are very safe and effective for all ages, and they are safe. I've tried to put it on my 1-year-old, but she tried to eat it. So I do think that the CDC is onto something with the whole 2 years and older thing. But you trust me, when she turns 2, if we're still in this, she's going to learn to wear a mask and not eat it. So where do we go from here? So DHEC Public Health. Believe it or not, we existed pre-COVID. We will continue to exist. But here's the thing, and this is why I tell people, the radio and TV stuff, it's not a good sign. It's definitely not a good sign when you're seeing your public health officials on TV a lot. We like to be behind the scenes and keep things under control, and you never know that we were there or doing anything. So that's what we prefer. That's what we want to go back to, is all the behind the scenes work that we do. At this point, we have 1,900 roughly staff pre-pandemic. We are, I think, around 2,200, 2,300 currently. We certainly have staffed up, and plenty of those will stay with us longer term. We have 4 public health regions, as you can see colored here, so you're in the upstate one. They do have the 74 service sites. We have a 1 county health department, at least 1 in every county. Some of the counties like Charleston, they really still just have 1 health department, but it's 2 different locations. It's too big to put all in one. So they split some of the parts into 2 different ones. We also have central office in Columbia, Bull Street. Yes, we are in the old asylum. I can look out my window and see the big stone letters carved on the back of it that says asylum. There have been plenty of Traxler family jokes about that. But so a lot of the behind the scenes work too goes on there. And that's where we're doing things like applying for the federal grants, setting policy, setting the kind of standard operating procedures, doing a lot of the monitoring. A lot of the data and such gets collected out in the regions and then goes to our analysts and epidemiologists in central office. We've got 7 bureaus and 4 offices now. So it ranges everything from our WIC program, community nutrition, to chronic disease work, our public health preparedness, which are our emergency response folks that are really good for the record at hurricanes, but we're a little surprised with the pandemic, but have done an excellent job. Certainly our communicable disease, which includes immunizations, tuberculosis, all diseases, including COVID. We have maternal and child health. We have our public health lab that really stepped up to the plate during this pandemic. And then we have offices. We have our diversity, equity, and inclusion office that was just created a couple years ago. Our newly formed COVID coordination office, as we move out of our incident command structure and into a more programmatic approach. And things like our state health improvement office. What are our focuses as we go beyond COVID? We will certainly still, don't worry, be focused on following all the latest with COVID. And the lawyer's daughter in me feels the need to put this disclaimer, you know, this is not necessarily complete and it's subject to change, okay? For the first year of the pandemic, when I gave presentations, my first slide was always that it was a rapidly evolving event and all the information in the presentation was subject to change because it often would change, potentially even by the time I gave the presentation after creating it. So workforce retention and recruitment. Public health, along with healthcare, has lost a large part of its workforce through this pandemic. You know, public health has not always been everyone's favorite folks during this. And so we have lost staff, and we're very focused on the retention and recruitment. Building infrastructure. We need a new lab, and we're working with the legislature to try to get funding for that. The physical building is about 40 years old. Our roof has a separate roof because there's so many pipes and vents that had to punch out through it as the lab evolved over the last 40 years that there became so many leaks that now that roof, literally you can stand on the first roof between the roofs. Like 10 feet above it, there's another roof that was built up. So we just are out of space. I have learned more about HVAC during my time in this role, because the HVAC system, when it was built, was not designed to handle the amount of heat that's generated by all the new equipment. And so our chillers, things I didn't know existed, will often go down and we don't have enough backup chillers. So we will have literally at times big box fans pointing at specimens. Things I never thought I'd do was write a note asking the airline to please allow one of our lab employees on the plane holding newborn screening specimens Memorial Day weekend to fly them to Nashville, Tennessee. Thankfully, Tennessee Department of Health was willing to help us out when our HVAC went down in our newborn screening, which is very time sensitive. Those equipment I've learned are also very sensitive to temperature and humidity, unfortunately for South Carolina. And so to make sure we got those results in a timely fashion to folks, we put them on a plane with somebody and flew them to Tennessee so they could run them for us. So I am optimistic about us getting a new lab. We're also the only biosafety level 3 lab in the state. So suspicious powders, suspicious substances, if they can't be identified out in the field, you know, with one of the measuring devices there, will come often to our lab. So we work closely not only with SLED, but with FBI and all also. So that's something. We're also the only rabies lab in the state to test, and we don't test humans, we test the animals. So animal heads go to our lab for rabies testing. Yes, it's as bad as it sounds. I used to do the rabies consults in my role pre-COVID, and yes, they won't take the whole animal. We also are doing data modernization initiatives. We have a bunch of databases, and especially they have been overwhelmed by the amount of data dumped into them with COVID. And a lot of them don't always talk to each other the easiest way. And where we used to be able to finagle it with some, you know, manual work on the side, there's too much volume now. So really getting those modernized and talking to each other. That's a language I've not yet mastered. I've learned about HVAC and I've learned about things like ventilation and school buses and all, but the IT piece is still a little bit out of my grasp. The opioid and substance abuse epidemic. We just recently got our finalized numbers from CDC for opioid and drug overdose deaths in 2020 in South Carolina. And compared to that first year of the pandemic, compared to the year before, opioid overdoses went up 53%, or drug overdose deaths, I should say. The opioid ones went up almost 60%. And fentanyl was a large portion. That was significant. It was over 100% increase in terms of deaths that involved fentanyl. So certainly we're working closely with our partners at DHEC and at Mental Health on that. Maternal and infant mortality. We're improving. We just recently put out our infant mortality report, where our overall infant mortality improved, but the disparities got worse. Certain, Black babies, I can't remember, I don't think Hispanic, but I think it was just racially done, had an increase. So while the overall mortality rate came down and was better for the state, it actually increased. And so the gap widened between white and Black babies. And so we are fighting that very hard. That goes into this health equity piece here at the bottom. We want to eliminate those disparities throughout the state. Childhood immunizations. A lot of people became against vaccines during COVID-19. And so we have that combined with parents not wanting to take their kids to a doctor's office where they might get COVID. They were afraid. It has meant that a lot of children have ended up behind in their vaccines. Before I came here, approved a press release going out talking about the importance of getting children vaccinated on time, because we have just recently seen the first 2 varicella or chickenpox outbreaks in the state the last couple of years. And so that is a vaccine preventable disease now. And so really it's stressing the importance of the children getting those. We have prevented things like measles, H flu, diseases that a generation ago were more commonplace and did result in babies and children dying, now are not a problem if you have vaccination rates high enough. And then certainly an all-hazard public health preparedness, knowing that there will be another pandemic. With as much as we're interacting with our environment worldwide, interacting with animals and the environment, there will be another pandemic. It will not be COVID-19. It may not even be a coronavirus, but so what is it? And we just need to be prepared. We need to be prepared for the natural disasters, not even just hurricanes, which South Carolina is very good at, but others too. So these are some of the priorities that we're going to be focusing on as we move forward along with COVID. And so with that, I want to thank you all for your attention and ask any questions. So I do think that it is really too early to kind of rule any kind of final judgment. And I think it'll be hard because it's not comparing apples to oranges. All these states that you're talking about are very different ones from the beginning. I do think that certainly South Carolina, I think, has done a good job of keeping the economy open, keeping society going. I think that we have done an okay to good job on public health responses, but those have been more on the individual level rather than policies or procedures. So one of the things I tell folks is it's okay to follow the rules, even if they're not rules. Even if there's not a mandate, if you know it's the right thing to do, then do it for yourself or your neighbor. And so I think that we've seen plenty of that, but I do think we had plenty of room to grow in that regard. Someone back over here. And I don't think that's unique to South Carolina. I think this pandemic has been politicized across the board. And it is unfortunate. And so what I do is continue to to try to take politics out of it, is continue to speak the science and the data, and leave the politics out. And people then, I'm going to continue telling them the truth. And so hopefully they will listen. Sure. Are you asking about, so the question is about the safety of the COVID vaccine for women in childbearing age or who are pregnant? So there is actually data that shows that getting vaccinated against COVID-19 while pregnant is protective. It saves mothers and babies' lives. And so we know there's data to show that if you're infected while pregnant, that you have higher risk of severe disease and having to be hospitalized. They're higher risk of things like preterm labor, having a baby prematurely. And so those can be prevented by getting vaccinated. In addition, there's been a study that's come out within the last few months that was very well done that showed that women who were vaccinated while pregnant pass antibodies on to their babies. And 61% of those babies at 6 months old were still showing immunity to infection. And so, that really helps bridge the gap then until even one day when the 6-month-olds and up are eligible for vaccination. In addition, there's no data that shows that the vaccine causes infertility, causes miscarriages, has any adverse effect. And they certainly are keeping a close eye on it because of reports that have emerged, and especially in the mainstream media about that, but there's no data to suggest that currently. Sure. So the question was about whether we're tracking the timing and correlation with Epstein-Barr virus infection and COVID infection, and we are not. EBV is actually not reportable in most states. It's not reportable nationally to the CDC, and so it's not reportable in South Carolina. That is something that I suspect is being done on healthcare system level, where they have access to medical records without having to go through, jumping through the hoops of privacy, protection and such. So we are not at DHEC looking at that because we don't have all the data.
Thank you so much, Dr. Traxler. I think you can tell from the number of questions and the quality of those questions that this was a timely and well-received presentation. We are a better and healthier state because of the service of you and your colleagues. And in gratitude for your presentation today, we will be donating a book to Alexander Elementary, our Title I school. This was one of the practices commended to me actually at a recent Rotary conference for presidents-elect, that we should start donating books to schools, and I thought we are already doing that in this club, and I was proud of that fact. Before I close this, I'd like to invite Rob Rowan up to give a very, very quick update about the flyer on your table.
So you know about this great conference that we're putting on, the Rotary Peace Conference, and I'm involved in that. But next week, if you're free, I'm going to tell you about something amazing. I'm putting on Global Upstate World Conference. It's a conference of international business, and it's also foreign affairs. We have the former ambassador to the Ukraine going to be talking about Russia. We have 3 other former ambassadors coming. We also have a military general from Pakistan and another one from Denmark. They're serving at Central Command. We have a whole panels of international business. Take a look at this. You may enjoy coming for part of it. You don't have to come for the whole thing, but it's going to be an amazing chance to learn what's behind the scenes in foreign affairs and international business. So please join us.
And we have our drawing for those who have been bringing guests. So thank you, Dr. Traxler. Remember the Peace and Conflict Resolution Conference coming up on May 12th. That is going to be a fabulous event. Career Day on April 12th will be our next meeting, and we look forward to seeing you all at all of those things. So please stand and join with me in the 4-way test. The things we think, say, and do, is it the truth? Is it fair to all concerned? Will it build goodwill and better friendships? Will it be beneficial to all concerned? Thank you for being here today. We are adjourned.